Chest tube management. This training will cover why a patient has a chest tube, how the drainage system works, and what to do if there is a dislodgement. Why does my patient have a chest tube? They could have a pneumothorax, which is a collection of air in the pleural space, a hemothorax, a collection of blood in the pleural space, or a pleural effusion, which is a buildup of excess fluid in the pleural space. Pneumothorax types. A closed pneumothorax is when the chest wall is still intact, but the pleural space is compromised. Usually air is leaking from the lung itself and getting into the pleural space. This is seen in people with chronic lung disease, emphysema, cystic fibrosis, tuberculosis, etc., and can lead to a tension pneumo if not treated. An open pneumothorax is when the chest wall and the pleural space have been punctured and air is getting in from the outside environment into the pleural space. This is caused by trauma, also known as the sucking wound. A tension pneumothorax is when air is leaking into the pleural space through a tear in the lung and has no means of escape. It's a one-way leaking valve and compresses the lung into eventual collapse. This is life-threatening emergency as the pressure will cause the heart, vessels, and trachea to shift to the unaffected side of the chest, and the unaffected lung may then collapse. Cardiac output and venous return are severely affected. Late signs and symptoms are distended neck veins, tracheal deviation, and muffled heart sounds. We treat pleural effusions with a chest tube drainage system. For a pneumothorax, air in the pleural space, you may see a smaller type of system placed in the upper thoracic area called a Heimlich valve. It's a one-way valve that allows air to escape. For this training, we are going to focus on the drainage system. Pleural effusions are most commonly caused by congestive heart failure, pneumonia, lung cancer, or a pulmonary embolism. At SMCS, we use a dry suction chamber. We do not use water seal. Let's look at these different components. On the front face, we have the dry suction control knob, negative pressure indicator window, the air leak meter, and the collection chamber denoted in mLs. Here at the top, we have the suction port where the tubing is connected to the suction, the needleless injector site, high negativity release valve, and the patient tubing connection. At the bottom, there is a base stand that also swivels to make it extra secure. The device works with suction. Check the order for what negative pressure the provider has ordered. In adults, the most common order you will see is 20 centimeters of water. In this example, the chamber is set to 20. The regulator on the wall must also be set to at least 20. The regulator on the wall does not manage the patient pressures. This is set by the device. For example, if your device is set to 20 and the wall regulator is at 40, that's okay, as the suction is determined by the device. Let's just say the wall regulator is set at 10, but the device is supposed to be at 20. You're only going to get 10 because the main vacuum is only at 10. This is why you want the wall set to at least what the device should be, or even greater, but never less than. Now let's say your patient has been set at 20, but now the provider wants you to decrease the negative pressure to 10. You can adjust the pressure by turning the dial, but this is not all. The system still has a negative pressure of 20 in it. You must release that extra pressure by pressing down on the negative pressure release valve here. You might even hear the air escape with a quiet hissing sound. Make sure your suction is working by checking here that there is a little orange ball or cap floating in this window. To set up a new drainage system, remove from the package. Set up the stand and swivel the foot outward to make a wider foot base. To set up the air leak meter, remove the 20 cc syringe from the back of the drainage system. Instill the saline into the needleless injector port. There is a blue dye inside the air leak chamber. Attach the suction tubing to the suction port and turn on the wall suction. Then attach the tubing to the patient. Tidling with inspiration and expiration is to be expected, but if you have continuous bubbling in the air leak meter, this would be indicative of a low air leak. As you can see, chamber 1 has continuous bubbles. If there's a moderate air leak, you'll see continuous bubbling through multiple chambers like 3 and 4. With a high air leak, all of the chambers will have bubbles, 7 out of 7 high air leak. What if the patient needs a chest tube inserted at the bedside? Get your resources stat. Call RRT, your charge nurse, and respiratory therapy. The supplies needed are the chest tube insertion kit, and the drainage system. All of these are kept together in what's known as the chest tube basket in central supply. It has everything you need. In the ED, these are kept in the C lockers, and in the ICU, the line carts. Caring for the patient with the chest tube, the do's and don'ts. Do assess every shift and PRN. You want to assess the drainage, the amount, color, and character, the tubing patency, the insertion site for an intact dressing, insertion site area, subcutaneous emphysema, that's that Rice Krispie sound under the skin, breath sounds, rate, symmetry pattern, and the patient comfort level and pain. You also want to assess the drainage system every shift and PRN. You want to make sure you keep the system below the level of the patient's chest at all times. Check for bubbling and air leaks. Mark the drainage level and document the drainage on the I&O flow sheet. For the drainage system, never kink or loop the tubing. Never clamp the tubing unless changing the system, which is very brief, or if the provider orders a clamping to trial the patient. This puts your patient at risk of tension pneumo. Discuss with doctor and make sure communication is very clear on when tubing should and should not be clamped. Do not milk the tubing. This increases the intrapleural pressures. Do not knock the system over. Make sure you keep it secured. In case of an accidental dislodgement, it is policy that these supplies be kept at bedside at all times for emergencies. You want 2 rubber-tipped hemostats, betadine pads, occlusive dressing, gauze, and tape. We'll show you later on how to use these items. I recommend keeping these at the drainage system just in case your patient is ambulatory and walking the halls. Accidental dislodgement can occur in multiple places. The chest tube to the drainage tubing, the drain tubing to the drainage device, or the chest tube can come out of the insertion site. If the tubing becomes dislodged from the drainage system, don't panic. Stay calm. Make sure you don't kink the tubing. You don't want to accidentally cause a tension pneumo. Instead, we want to get this hooked back up to suction as quickly and safely as possible, but first we're going to use the iodine to clean both ends before reconnecting. After connecting, assess the patient. If you find that the tubing has become disconnected from the chest tube itself, don't panic. Stay calm. We want to connect the 2 tubes back together as quickly as possible. We also need to make sure that it is clean before we connect it. It has been sitting on the floor. Use your iodine and clean both ends of the tube before reconnecting. After getting your tubing connected, assess your patient. It's recommended that you tape the 2 tubes together to avoid this from happening. If you find that the patient has dislodged the tube or it's come out completely, stay calm. Don't panic. We want to get that hole covered up immediately. This is what your occlusive dressing is for. We typically use a petroleum-based dressing. Open the dressing and place it directly over the opening. This will help prevent air from escaping inside of that pleural cavity. Next, place your 4x4s over the dressing. Use some tape to hold everything in place. Call the provider immediately. Stay with the patient. You do not want them to develop a tension pneumo while this is going on. We have covered up the hole and there's no way for the air to escape. Complete your documentation of the chest tube under the LDA flow sheet. For those working in the pediatric population, please see the pediatric chest tube and attached documents for further information.